Huh?
I will.
Because, okay.
I've looked at it before. It would definitely be nice, because 4 hours is a lot of time to miss if you can't make one day, so it helps if you do that.
When you can also listen to Ethan. You guys remember Ethan?
Yes.
You can listen to his class stuff, too. That should be accessible to you. Okay, so if it's not me that you hear on some of them, you'll hear others. And so he may have a different way of describing or explaining so that you guys can. All right? All right.
Are you going to have it on Monday, even though you're doing, splinting stuff and all that?
It's only for lectures. Sorry, dude. Out of luck. Okay, so now let's talk as normal progression would have it. We've talked about trauma in pregnancy, so now let's talk about pediatric trauma, right? That just kind of seems like the natural way to go. So how many of y'all would kind of go, kids are easy to deal with, they're just little people, there's not a whole lot of differences?
Water doing trauma, right?
And how many of you guys think they're like little adults?
I think it can go
It depends on
completely the opposite. I think they could be super easy, or they can be the hardest thing in the world, depending on what kind of thing you get.
Well, and some of that's true. But what I want you to understand, though, is there are some significant differences in pediatric patients as you're dealing with, and forget the personality, okay? Forget the kind of kid you're dealing with. Pediatrics alone are not little adults, okay? They are not just little humans, all right? So that's why it's really important that we kind of understand about pediatric trauma, okay? Plus, remember, it's the #1 cause of death, ages 4 to 44. Okay, kind of scary stuff. This is the #1 killer, pediatric trauma, after the neonatal period. So that would be that first month of life where they have, congenital defects, those kind of things. Okay. Priorities are the same as adults, so it's still airway, breathing, circulation. Okay. Let's talk about some of the differences. So a pediatric airway is significantly different. Okay, what makes a pediatric airway different?
It's smaller, shorter.
Okay, so it is smaller. Guess what else? Their tongue isn't bigger than yours, but relative to the size of the tongue and the size of the oral pharynx, significantly larger. Okay, so we're talking relative here. Okay, they also have a more floppy epiglottis. Okay, you guys remember what the epiglottis is?
The flap.
Yeah, the flap. They also have a big head. So remember when we were doing spinal mobilization or spinal motion restriction, and we talked about those buzzwords? You guys remember the buzzwords? Inline, neutral, position. Well, because of their big head, that can make airway compromise simply a positional problem on our pediatric patients. Okay? You have got to understand that. Are you with me? Makes sense? Okay. They have a small mouth, right? They have a shorter mandible, and then you're right. Their airway's shorter, and it's also shaped more like a cone. Okay. So when we start talking about some airways, some of these kids may only have an airway the size of this straw. So when I start talking about position, what happens when I kink it like this? Right? It has a significant impact on flow through the straw. Same concept. Okay?
Is there an age?
It's progressive. Okay? And children don't mouth breathe well. Right? Remember the other sign of respiratory compromise on a pediatric patient? Have we talked about that? Nasal flaring, right? Because they're predominant nose breathers. They're obligate nose breathers, in fact. Okay? Especially depending on the size of the kid. That's why a kiddo with a congestion, a stopped up nose, has difficulty eating if they're still on a bottle because they can't breathe while they eat if they have congested nose. Okay? So this is the prime example of positioning the airway based on the size of the head. So what happens to that first kid, that top picture? What happens to his airway? Yeah. Essentially it closes off, right? Okay? How do they fix it? No, because you got to be careful because you can hyperextend these guys really easily. So what did you say, Shaver? Yeah, and the size of it is going to depend on the size of your kid. So this is a lot when they talked about, I think it was you, Jacob. You talked about padding when we start putting them on a board. If you have to use an adult board for a pediatric patient, you're really going to have to pay close attention to the padding under the back. Now, if you get a pediatric board, a lot of them have either a dip for the head or padding under the shoulders to kind of automatically do this. Again, that's going to depend on the size of the kid. Okay? Neck overextension may also obstruct the airway. We already kind of talked about that due to that high glottis. Use the sniffing position if a neck injury isn't suspected. So, like if you were going to smell the flowers. Okay? And then a chin lift is important to get the tongue out of the way. Right? Because remember, they got the big tongue in comparison to the size of their oropharynx or the size of their mouth. They have small passages that obstruct very easily. Okay? Predominantly, kids have problems with airway and breathing compromise. Okay? They also, and we talked about this, I know I've mentioned this to you before, right? Remember how I told you they have more horizontal ribs? Where if you look at ours, they kind of angle down, kind of like so. Pediatrics kind of tend to almost come horizontal. They have a higher arch right here, so remember they don't have as much protection for that liver and spleen that we kind of talked about, remember? You guys remember talking about that when we talked about thoracic and abdominal trauma? Okay? Also, swallowed air or overaggressive bagging, right, causes gastric insufflation, which has a profound effect on these kids' ability to breathe. Profound effect. It is extremely important not to overbag them because they have a lot of air in their belly. They can't get the, kind of like me, they can't get that pull. They don't have the capacity to do that if you fill up their tummy. Okay? Oh, and also make sure you anticipate the need to ventilate. Now, aggressive airway treatments are important when it comes to airway and breathing when it comes to pediatric patients because they don't have some of the same abilities to protect or compensate. Okay? It's important to know what those are. Okay? Fast breathing can be normal, right? Because the smaller they are, the faster they breathe, and then as they get older, they kind of slow that breathing down. Same goes with their heart rate. Okay? Breathing at a normal rate for an adult. Now again, we've talked a lot about the rates, 10 to 20, 12 to 24, kind of in that range, is going to be slow or too slow for some of your pediatric patients. Okay? That is a pretty significant indication of respiratory failure. Okay? Auscultation of the chest. So when you listen to their chest, this can be quite difficult. Okay? Why do you think it's difficult? No, it's not. It's not their placement of their organs.
Smaller.
Well, yeah. How does that play a part, though, Jacob?
This sounds.
They can't take deep breaths.
They're
Well,
not strong. They don't have the structure that.
So, how about this? When we start thinking about they're small, they're also much closer together. So it's easy to hear the same lung sounds. Like they may only have a poor lung sound here, but if I listen over here, I can hear lung sounds across their chest. Their chest is so small, they get really resonant, so you can hear everything. Okay, so you have to be real careful if it doesn't sound the same on one side. If it's significantly diminished and they have chest problems, then you probably need to be thinking pneumothorax, even though you kind of go, but I can hear it. But you may hear it even if it's absent, but you're actually hearing across the chest to the other lung.
Do the pediatric stethoscopes, do they help with that at all?
I haven't had much of a difference.
What's the normal rate again for pediatrics?
Depends on their age. Predominantly depends on their age. So remember, birth can be, 30 to 50 or 40 to 50, and then it drops down at 6 months to about 30, and then at a year, about 30 to 25-ish or something like that. And again, it's going to depend on what literature you read. And then they kind of slowly progress to adolescents are generally pretty close to the same respiratory rate as us. Okay? They have high metabolic rates. Between that and then their low reserve capacities, they have a high sensitivity to airway and breathing problems. Okay? And then oxygenate and ventilate aggressively. Okay? We kind of already talked about that. Know your parameters. Know when you should probably help those kids out. Circulation. Rapid control of external bleeding is really important, right? Because they have small blood volume. Okay? They compromise so well that sometimes you can miss it if you're not looking, right? So when do adults start having changes in their perfusion or their blood pressure? At what stage? Remember, there's 3 stages of shock. There's compensated, decompensated, and irreversible. At what stage do adults start dropping blood pressure? You guys know when pediatric patients start dropping blood pressure? Yeah. At that kind of that break almost between decompensated and irreversible shock. For pediatrics? I'm not giving you the answers to the quiz. Is that what you're asking me? Yeah. Sorry. If we have time, we'll go over them. Okay, if we have time. Okay. Sudden decompensation, onset of irreversible shock can occur, and that's just generally if we miss those signs early, right? Because kids, what do we know about kids and their heart rates? We know about the respiratory rate. We talked that the respiratory rate goes up, or their respiratory rate is faster anyway. How about their heart rate? It's also faster. So it's important that we recognize early that it's a little bit faster than probably it should be. Does that make sense? They're going to be more subtle when they're incompensated, okay, because they already have fast breathing and heart rates. You understand what I mean? Yeah? Okay. BP monitoring, again, and this is the same with adults. We kind of talked about that, right? Adults, you can trend. Pediatric patients, you're not going to get the trending with the blood pressure like you would. So BP on a pediatric patient is a very poor indicator for whether they're in shock or not. Okay? So how are we going to assess perfusion on our pediatric patients? Peripheral pulses, rate and quality. Now again, that's going to depend on their size, right? Have you ever tried to get a radial pulse on or even a carotid on a 7-month-old? They have like no neck. They have this little short, fat neck. It's kind of hard to get to. It's chubby. There's rolls, right? So you're going to have some. So some of this is going to depend on the size of your patient. Okay, skin color and temperature. Okay, silence is not golden. So level of consciousness. So if there is a baby that is kind of quiet, that is the one that I am the most concerned about. Okay. And then capillary refill. Where can we check capillary refill in pediatric patients? Chest, forehead. That's more for central. Feet, hands, right? So you may not check nail beds, but you can check it here, kind of on their palms or on the bottom of their feet. Okay? No, you're right. Chest, absolutely. So if they're in a cold environment, I want to kind of check and see what's the difference between their capillary refill at their central location and their peripheral location. I may kind of do this and count them out and see. Because remember what happens, I start shunting. Where do I shunt blood from? Extremities to the core. Okay, so keep that in mind when you're determining kind of how I'm going to do it, right? If it's a nice warm day out like today, and I have a 4-second peripheral cap refill of a pediatric patient and a 2-second, is that kid compensating or are they in shock or not? Yeah, absolutely they are. Okay? So, how are we going to take care of them? Airway management, airway management, airway management, and that includes position. Okay? So when you think airway on a pediatric patient, you should absolutely think position early. Okay? 100% O2. Again, they don't have the reserves. So they have high metabolic rates, and they have a lot of O2 demand, and they don't have the reserves. You've got to give them a lot of oxygen. They're kind of like your pregnant patients. Okay? What's your question?
Just high flow to 100% O2, is that the same thing?
Yes. Yep. Consider early ventilation. So don't wait until, again, if it's kind of a should I ventilate, ventilate. What is tricky about deciding when to ventilate and when not to ventilate when I'm talking about a pediatric patient? What's the tricky part to this?
You don't know whether they have an airway obstruction.
They're fast breathing.
Say it louder.
They're fast breathing.
Yeah, they breathe fast anyway. So I kind of need to have an idea of normal ranges for pediatric patients. Because I may look at a pediatric patient and go, oh no, they're breathing adequately. But in fact, they're breathing too slow for them or too fast for them where they should be. Okay, so that's important to note. Prevent hypothermia. Remember, they don't have the ability, they have that thin skin. They also don't have the sub-Q fat. So it's much easier for them to drop their temperature. Okay, they don't have the thermal regulators that some of us do. Okay, so keep in mind, prevent hypothermia. Okay, you got to keep them warm and covered. Now, yes, we expose them just like we expose everybody else, but we need to cover them up pretty quickly because they can't maintain their body temperature. And remember, your really small kids, they lose a lot of heat through their head. Okay?
On the ventilation, is it the same as adults? Like when in doubt, just
Yeah, absolutely. Absolutely. Okay? Head trauma is a major cause of death because they have large heads, thin skin, and what do we know about calcification of bone?
it hasn't really.
Yeah, it happens later. It happens later. So they don't have quite the protections that we have either. Right? They also have poor muscle control. Okay? And then diffuse edema is generally more common than an intracranial hematoma. Now, that's going to depend on injury, but it is overall more common. So basically, I'll have a lot of this because of that lack of muscle control that will cause. You remember that? Remember I mentioned like something called coup contre coup, where it's kind of the brain hitting the front and back and front and back. Same concept because they don't have the muscle control to maintain that. Right? They may have just diffuse edema. Okay?
What is diffuse edema?
Just swelling, basically, from hitting back and forth. So it won't be localized. Yes, yes. It won't be localized as much. It'll just be diffuse kind of everywhere. Okay? Monitor for signs of increased intracranial pressure. Remember that ICP. So, AVPU. What am I looking for in my pupils? Dilation, constriction, and are they equal? Right? I have to look at both of them and see, are they the same size and are they responding the same? Okay? Vomiting is a pretty significant indication of a head injury or stroke, period. Alright? Because the increase in intracranial pressure puts pressure and causes me to vomit. Cushing's triad. How many of you guys knew presentation of Cushing's triad? William.
Dilated pupils, jugular vein distension. I think there's
Yeah. No. What do you got? What do you got for it, Shaver?
I mean, I kind of guessed, but I guessed right that it was a head trauma. So I assumed the BP would go up and the heart rate would go down,
Okay.
and then the pupil dilation would happen to the injured side.
Okay. So they may have abnormal pupils generally. They're going to have an increased, usually rapid irregular breathing pattern with a low heart rate and high blood pressure.
So what does that injury look like?
Why did you
There's
say?
3 different levels of the brain, you know what I mean? You got that.
Cushing's triad indicates member herniation, which is where basically my skull is enclosed completely. And so as I continue to bleed or get edematous or get cerebral spinal fluid, most of the time when we're talking about trauma, we're talking more bleeding, right?
But I think he was saying, like, because there's a difference between epidural hematoma Trauma and
Right. But Cushing's triad is different than that.
both of those?
Yes. Cushing's triad is when the brain is herniating. Remember, where's my one opening in my skull? The bottom, in the back, where the brainstem is, which is where my cardiac and respiratory center is, which is why I get that rapid irregular breathing pattern. Okay? But a herniation, or Cushing's triad, says that I've got so much stuff in my head that it's starting to push down through that hole.
And that can happen on anybody, and not just...
Yes.
That's why I asked you. I was like, people with pediatric, or people who've had kids already. For some reason, I... Really
But it is not specific to pediatric patients.
I know. You brought it up several times. That's it.
Yeah, I know. I have.
Can other head injuries turn into a Cushing's triad?
Yes. Cushing's triad simply says there's so much going on in the head that now my brain is starting to push down through that hole. That's it. That's all Cushing's triad is. So it could be a number of type of head injuries. Okay? Hyperventilate these folks if they have head injury. Okay? Only if they have a head injury. Resuscitate hypovolemic shock aggressively. Well, high flow to position, right? When is the only time that I can put a person with their legs elevated?
Shock. Oh, you mean...
What kind of shock? Yeah, hypovolemic is significant, right? I want to get the fluids from down here to up here, which is what they're talking about here, right? Did I confuse you?
Yeah, that's fine. I thought... I didn't know you were talking about the positioning of where they were standing. I thought you were how you treat it. That was a different way than what anything was.
But early recognition is significantly important because they need, aggressive resuscitation. Call ALS early. Okay? Spinal trauma, uncommon. However, when you do see it, it's usually that C1, C2, C3. What happens when you have C1, C2, C3?
Paraplegic.
No, that's
Respiratory.
Death. Death.
That's right here, right?
That's your first through third,
Right.
which is where your,
Brainstem is.
yeah,
Which is pretty much a
done.
internal decapitation. Is that what they refer to as whenever it's in that range?
I don't know that I've ever heard that term, but probably.
Is that for everybody or just babies?
Predominantly pediatrics. Now, dislocations are more common than fractures, okay? Why is that?
Their bones are.
Because they're stretchy. There's a reason they call them bouncing baby boys, okay? Suspect if trauma involves sudden deceleration, head injuries, decreased LOC. Okay? I cannot stress this enough. Resist the temptation to pick the kid up and run. You'll see people do it. They lose their composure. They kind of go, I just need to go, I need to go, I need to go, I need to go. Well, there are some things that we need to do first. Okay? We need to make sure if they need spinal motion restriction, that we do it. We need to make sure that if we need airway, breathing, and circulatory addressing, we need to do that. Okay? It's very difficult sometimes to keep your composure in general when you deal with pediatric patients. You need to figure out how to do it, because if you don't, you will cause further damage to some of these kids. Do you want to live with that on your conscience? Okay, so don't pick them up and run. And you'll see people come and you'll hear it called flaming baby syndrome. In the event, people freak out, okay, bystanders alike, first responders, whomever. Oh my God, you got to come take care of the kid, you got to come take care of the kid, you got to... Nope. Right, some of those are the hardest calls to do. You still have to do it. Okay? All right, chest trauma, second only to head. As a cause of traumatic death, 90% of it's blunt trauma. Okay, penetrating trauma is less likely in a pediatric patient. Chest walls are flexible, so what does that mean for pediatric patients?
Yeah, pretty hard, blunt trauma.
They hurt their organs before they would rib.
Yeah, it's not uncommon for them to have significant underlying damage to either, to organs or organ systems, but not have rib fractures. Okay? There you go. They have a mobile mediastinum, which means basically they have a poor tension pneumo tolerance. Okay, they don't tolerate those things very well, and their chest is pretty small. It doesn't take a whole lot. Okay, and then limited respiratory reserve. So in general, they already don't have very good muscular. Okay, so when we rely on those intercostal muscles, they don't have that. So the things that we use as a reserve, they kind of don't have some of those reserve capacities. Okay. Abdominal is the most common cause for trauma in pediatrics. It's usually blunt. Okay. Why is abdominal injuries or trauma most common? Well, they do have big old bellies. They don't have developed muscles, right? Any of you guys watch boxing or UFC or anything like that? So what's the first line of defense if somebody's going for a body shot? What do you see these guys do? They flex because the tension on those muscles helps protect those organs, okay? So they don't have the advanced muscles for that. They also don't have that rib cage protection again, okay? That high broad costal arch that we talked about. Liver and spleen injuries are more common than in adults. Okay, we're a little bit more guarded. Okay, tenderness equals significant trauma until proven otherwise, period. It doesn't matter. Distension, significant trauma until proven otherwise, period. Be very cautious. Pediatric patients, they will likely vomit. Kids puke, and they do it regularly. There's always something in their belly, so have your suction ready. Whether it's abdominal or head, okay? Vomit is a common airway problem. And I know I kind of threw that in there, but I wanted to remind you guys. Kids all the time are eating and drinking and stuff, okay? Extremity trauma is never severe enough to bypass your ABCs or to go to an extremity before you assess head, thorax, and abdomen, period. Okay? It's real easy to get those distracting injuries, especially in a pediatric patient. It's real easy to be distracted by those. You have got to first check head, chest, and abdomen, because that head, chest, and abdomen will kill them long before an extremity injury will. Okay? Pliant bones, of course, absorb and even dissipate significant force. So green stick fractures are common. Mark went over green stick fracture with you guys on Monday. You remember what a green stick fracture is?
Yeah.
What?
Got a break on one end, but like a rippling, or like sticks back on.
Yeah, it's like a bend. So if you've ever, anybody here ever have to go get your own switches? Granny ever make you go get your own switch? You wanted to avoid those green ones, right? Because they were very flexible and pliable. So if you get a stick, literally, and you try to break it, depending on how green it is, or anybody ever had a wood stove, you know that trying to break one of those green sticks is much more difficult. So you may break it on one side, but otherwise it's kind of gummy and flexible on the other side. So it's like a partial break, if you will. Okay? And then treat painful, tenderness, etc. of the extremities as a fracture. All right? Burns. Children account for 50% of burn admissions and 33% of burn deaths. Yeah, what do you think about that, Shay? That's high, isn't it? Yeah. They have a large body surface area, and so that increases not only their fluid loss, but also their heat loss. So that's problematic for them. Okay? Remember we talked, they also don't have that sub-Q fat that plays a role too. Okay? And then smaller airway equals higher possibility for obstruction, whether it's position or burn or both. Okay, real important. Consider the possibility of abuse anytime there's a burn if the story doesn't match the pattern. Now, what you'll learn is when I talked about stocking and gloving, not degloving, not what Mark talked with you guys about on Monday. You guys remember what degloving is? This is basically when it's a submersion. It's an intentional submersion, and they'll have very clear demarcation lines. Okay, because it hurts and those kids don't splash because it's very painful. It's almost paralyzing, if you will. So it's where parents will take feet or hands and dip them into hot water. Okay? And usually they're deeper burns because realistically what happens? When you touch something hot, you back up. In the event of non-accidental trauma, you can't do that. Okay? You'll see these injuries sometimes where kids will have a little donut on their rear end, like their butt cheeks aren't really that burned. I mean, they'll have superficial, but they don't have the extensive burn. Do you guys know why that is? Because they get held to the bottom of the tub, and the tub is generally colder than others. So, I mean, they'll have burns, but it'll be usually lesser of a degree. Okay? Questions on that?
I do have a question.
Yes, ma'am.
If we have an adult, we know she's